So I would love to introduce our beautiful speakers. This evening we have Liz Frost, PhD and Clinical Director of Integrative Family Medicine at Actional. Liz has been practicing at Integrative Family Medicine as a PA since August of 2015. She is particularly interested in women's health, coordination of care for patients with outside specialists, and enjoys meaningful and unique relationships with all of her patients. Dr. Brian Lewis has a medical doctorate, a master's in public health, and over 20 years of experience in integrative medicine. He enjoys supporting patients with a holistic approach to their health goals, and he draws from lifestyle, herbal, mind-body, and conventional Western medical approaches. He is the co-founder and medical director of Integrative Family Medicine at Actional. Whole team. And tonight's topic, of course, is menopause and unraveling the mysteries of both menopause and perimenopause. So perhaps that's a great place to start. Come on in and have a seat, if you feel comfortable. Can we start with what is menopause and what is perimenopause?
Well, I would like to first ask, what do people think menopause and perimenopause are? If you are inclined in the audience, if not, I'll just dive in.
I would like you to introduce yourself.
Oh, I always skip over that part. You're the first person to call me on it. My name is Ariana Figueroa, and I'm the health coach for Integrative Family Medicine. And I also get the joy of facilitating conversations like these. And that is who I am. Thank you. So again, menopause.
Thank you. Yeah.
So,
Anybody want to speak up to what they believe menopause is? And it's okay.
Oh.
It's okay. It's crickets.
It's a tough crowd, isn't it?
I have a great description that resonated with me from a doctor I was listening to in a podcast, and it was that menopause is the reverse of puberty in females.
yep. So for people who aren't here, we had a participant say that menopause is like the reverse of puberty. They
Yeah.
learned that and heard that from a physician.
Right, right.
Yeah. So yes, it is in many ways, and the easiest definition of natural menopause, which means a person who was born with ovaries in a uterus at some point in their life, ceases to have a menstrual period over the course of 12 months, consecutive months. It's a day in time. So there's really, the discussion is more about symptoms and the life before that moment and the symptoms in life after that moment. So menopause is 12 months without a menstrual cycle. Everything after that is technically postmenopause. We tend to call it menopause in general, it just gets grouped. And then everything leading up to that is peri or premenopause. So that's the start, I would say.
So how would you describe perimenopause?
The change in menstrual cycles and symptoms that correspond with those changes in cycles as a person approaches menopause. And it can be a wild ride, and it can be earlier than you think, it can be later than you think, and some people just end up one day in menopause and are like, I don't think I've had a period for 12 months. If there is...
We would know.
Yeah. You're right. Some people just arrived at that day. That also assumes that someone hasn't had a hysterectomy, that they don't have an IUD at the time of menopause, that they haven't had a DNC, or some other reason for why they aren't having regular bleeding. So it's a convenient definition if you're having regular cycles, and it's inconvenient if you're not. And in those cases, then we can rely on medication and sometimes, lab tests and sometimes symptom evaluation to really figure out what it is.
So menopause is when you've had 12 months and 1 day of no period,
Yes,
essentially.
that's a day in time.
A day in time.
Mm-hmm.
And perimenopause is the process of the menstrual cycle changing and having symptoms that are leading up towards that 12-month period without menstruation.
Even through those 12 months.
Even
Yes.
through those 12 months.
Mhm.
Okay. And then postmenopause is after.
Everything after.
Okay.
And it's worth noting that some people can be in the postmenopausal window for up to 40% of their lives, which is a long time. And it would be wonderful if that 40% could be wonderful and amazing and not a time that we are afraid of or struggle with. And that's part of why we're here today, is to try to break that open and change that paradigm.
Do you have anything you want to add to the...
Yeah. Excellent. I would say, with regret, that only in the past few years have I had the eyes to see perimenopause and how early it can start and how the symptoms arise. We're going to get into this more in a moment, but some of the symptoms of early perimenopause can actually start around 35. And as you progress through the years, because that decade, 40 to 50, there's just so much going on in life that can cause the same symptoms. Insomnia, lots going on in the 40s. Their kids are getting older, maybe they're going to school, maybe they're wild teens. All sorts of things can cause insomnia or weight changes or even menstrual changes that we may attribute to dietary things. And so it's easy to miss or to confuse what is perimenopause, what is all of life. And one of the reasons that we're giving this talk tonight is to kind of sort of unravel and realize that perimenopause doesn't happen isolated from life. It happens as part of life. Everything in life, your sleep, your nutrition, your relationship, your family, your environment, will affect your journey through perimenopause. When we look at cultures where they're less urban and there's less urban stress, perimenopause goes a lot smoother. So we see more symptomatic perimenopause and menopause in urban countries, more industrialized countries. So that speaks to it. So, yeah.
So maybe this is a good segue into what are the initial symptoms of perimenopause and how can they be distinguished from the travails of modern life? You know?
Good question. So typically, the thing that we hear about are the hot sweats and night sweats and hot flushes. Also called hot flushes, if anybody's hearing that in the vernacular. Those are the sort of cardinal things, and sleep disturbance, which can be in and of itself or because of night sweats and hot flashes. There are a lot of other symptoms that are becoming more and more recognized as part of the perimenopausal journey, and it is worth noting that estrogen receptors are in every single organ system in the body. So, symptoms can happen in every organ system in the body. So some of the weirder ones that I have learned about include frozen shoulder, which if you look at the data on that, women in their mid-40s, the rates are enormously high, and now it's sort of like, oh, maybe this is why. Skin changes, brain fog, headaches, palpitations, changes in vision, changes in how your skin responds, weight distribution throughout the body, gut health, bowel behavior, sexual health.
Everything.
Yeah, pretty much everything could be affected. And the degree of symptoms that someone might experience is really variable. Like I was sort of making a little bit of a funny around somebody just flying through this final year into menopause and not even really realizing it. And that does happen. It's not common. It's not the predominant experience in my clinical observation. But the fact that those receptors are everywhere and that estrogen goes down globally in the body, as does progesterone, the symptoms are variable both in systems and also in the individual. And so it's a unique experience for every person. And what one person might experience is very different than somebody else, but the point is that we're talking about it and recognizing what any of us might be going through or gone through.
What would cause these symptoms that are so potentially complete throughout the body to be missed or not discussed?
Well, that's a good question. Lack of research, for one. Lack of education on medical providers. Lack of overall global awareness among those of us going through it.
Yep. I have learned a lot from my patients in regards to this, and I've seen menopause this one family of Midwestern women with the sweetest accent, and they literally had a period 1 month and they just didn't, and everything was just fine and dandy. And I was just like, they are the anomaly, okay? I've seen the symptoms of perimenopause cause multiple divorces, lots of home stress, tension with families, kids. And as I said when we first started, I didn't necessarily have the eyes to see it until just recently to realize that this was part of menopause. And some of the symptoms with perimenopause and menopause can carry a stigma. It's like back in a time when depression and mental illness was stigmatized. And then now that we can understand what's going on in perimenopause a little better, there's no need for a stigma at all. And then it actually opens up an understanding that it has a pathway for supporting those changes. So here we go, a bunch of big words. So estrogen. Estrogen means egg. Estrogen promotes the maturation of the follicle producing egg. Progesterone promotes gestation. We actually have 3 estrogens in our body, men have 2. And these are typically rising in the first part of a woman's cycle. That promotes the release of the egg. After the egg is released, the follicle becomes something called the corpus luteum, which means the white body. It then starts producing progesterone. You can think estrogen does many things, but in the uterus, it causes the lining of the uterus to thicken. It's like putting the sheets on the bed, getting ready to receive a fertilized egg. Progesterone then starts to rise. You can think about progesterone as making the bed, getting the sheets all ready and tidy for that fertilized egg to come down. Towards the later part of the cycle, before the fertilized egg doesn't implant, progesterone will drop, and that's like pulling the sheets off the bed and having menses. Okay? This pattern is happening throughout a menstruating woman's life in a regular way. It's triggered by hormones in the brain, SH and LH. We don't need to get into that. But starting around age 35, a lot of women will experience a slow drop in progesterone. And this is one of the reasons why women have more difficulty carrying a baby after 35, because their progesterone levels start to drop down. Now, estrogen isn't just produced by the ovaries, it's also produced in our fat tissue, our adipose tissue, by an enzyme called aromatase. And estrogen can be converted from other hormones, including androgens in the body, like testosterone or DHEA. So at this point, women can become estrogen dominant, if you've heard that phrase, meaning that they have relatively more estrogen than they do progesterone, because progesterone tends to trend down early. We're going to nerd out hard. Here we go. So, in the brain, we're going to go top down. You have 3 estrogens, E1, 2, and 3, estrone, estradiol, and estriol.
Hold on, slow down. Estrone,
Estradiol.
estradiol.
Estriol.
Estriol.
Tricycle for 3.
Very similar sounding word.
Yes. Okay. Estradiol is the strongest. Estrone next. Estriol third. Okay. In the brain, as Liz said, there are estrogen receptors everywhere. In the brain, estrogen promotes serotonin, dopamine, and norepinephrine. To keep it simple, serotonin is the luminosity of life. Dopamine is the motivation. Norepinephrine is the energy. Okay. Progesterone has metabolites to do all sorts of things. One of them, allopregnanolone, calms us. It helps the GABA receptors. It helps with insomnia. It helps with anxiety. It also helps balance our immune system. So we see 2 times in life when autoimmune conditions spike. One is right after a delivered a baby. Progesterone goes from an all-time high to a crash. The other times in perimenopause is because progesterone is trending down. So progesterone does so many things. The most commonly noted ones are I can't sleep. My mind's racing. I'm like anxious all the time, unsettled in myself. Okay? Now, as we move down through the brain, you see estrogen having other effects. It affects the hypothalamus, that's the temperature regulation, that's the hot flashes and the night sweats. Move down a little more, we get down into the amygdala. Have you heard of the amygdala? The amygdala is that part of the brain, you say the thing, owl, owl,
Yeah.
okay.
Love
Is your owl nested? That's your amygdala, right? Amygdala has to do with our perception of threat, fight or flight. And so estrogen helps to calm the amygdala down. So as estrogen dips, our amygdala can become more reactive. And then we keep moving down through the body, and we see effects of the thyroid. We see insulin sensitivity decreases. Estrogen helps with insulin sensitivity. We see as we shift from estradiol to estrone, remember the 3 estrogens? Estradiol makes a woman look woman. Okay? Puts the adipose tissue around the hips. Estrone favors adipose tissue in the abdomen. It's one of the reasons why women see changes in their shape as they move through menopause. Progesterone helps the skin. It helps with wrinkles and lines and fullness. So all of these changes that are happening in perimenopause, this is the kicker. If it all happened in a steady way, it would be so much easier. But typically it doesn't, because you have these hormone levels that are fluctuating, and it's not this. Typically, it's this, a little this, a little this, a little this. And your body is playing this game where you have receptors on the cell that was mentioned, and they can upregulate and downregulate. When your estrogen levels go down, your cells respond by making more receptors. They're hungry for it, they're looking for it. And so when you're in menopause, the hormone levels are stable, and your receptors can kind of catch up and go, okay, we got what's going on, and your symptoms are stable. When you're in perimenopause and everything's fluctuating, your receptors are trying to catch up and then not catch up and not catch up. And it's what leads to these fluctuating symptoms that can be so distressing.
So it's like you're in a boat on the seas during a storm, and you like go up, and all the furniture slides this way. Then you go down, all the furniture slides this way, and in the middle you've got hot flashes and insomnia and other changes.
Can I throw a monkey wrench in it?
Mm-hmm.
Okay. So,
Wow.
so all these things are happening. 2 monkey wrenches. I'm just gonna, here we go.
Okay.
So your ovaries are primarily producing your estrogens and your progesterone. As you move into perimenopause, that job gets handed over to partly to your adrenal glands. Adrenal glands are promote cortisol in the body. People know about the adrenals and cortisols and the stress response. And so your adrenals are producing androgens and they're producing precursor hormones to estrogen that your other tissues will then go and convert into estrogen. If your adrenals are taxed from life, stress from the 40s, with movies about this, your adrenals are going to have a harder time taking the baton from your ovaries. Okay? So this is one of the reasons why female-bodied people in industrialized countries have a more symptomatic perimenopause. Because the ovaries are like, sorry, I'm a little busy here, dealing with all the things. Okay? And back to, let's just put it all together. Progesterone's dipping down. Now you're not sleeping so well. You're anxious. Your amygdala is not as soothed by all that estrogen. Starting to perceive more threat everywhere. Gears you up a little bit. So I'm anxious, perceiving threat. Oh, darn it. My serotonin and my dopamine and my norepinephrine are down. It's not feel like doing anything. Well, it's kind of too much. All that's happening in the midst of a busy life where in our 40s you got a lot going on. Okay? And not everybody will experience that. But more people do than we realize. And it's a conversation that we have been having because of a study that happened in the early 90s. Can you add on to this? I know just like...
Yeah, no.
Yeah.
What do you want to add?
Yeah.
No, I don't think so. I think the description that you gave about what's actually happening in the body during this transition time
Yeah.
is very helpful. And I think one question that's like the elephant in the room for me is like, why didn't I know this? when I was in school?
Yeah.
Why did it take me almost 9 years of just being in practice to really realize this was important? And I think that transitions nicely into the Women's Health Initiative and
It does.
what that study that some of you may remember, some of you may not.
Is anybody familiar with the Women's Health Initiative study? You are? So maybe raise your hand if you are. Most, most have.
Yeah.
Well, we could dive into what was it?
Sure.
We can go from there.
Yeah. I can deal with statistics.
Yeah.
But what's interesting to me is like how you like came about during the pandemic getting into this.
Yeah.
I think it's a story that's worth sharing.
Well, it's worth. So I went to PA school at Wake Forest. It's a good school. It's a 2-year master's program. I did a general PA degree. I got nothing that I can remember in terms of menopause education. Nothing. And I think you would probably say you got very little.
Very little, yeah.
4 years in medical school and probably not much in family med residency. Some
Well, I mean, this is what we used to do. We don't do that anymore.
because of the World Health Initiative study. So, late 1990s, the study, the Women's Health Initiative, thank you, took 5 years to recruit all of the participants, and the main goal of the study was to identify whether hormone therapy is helpful in preventing chronic illness, specifically cardiovascular disease and cardiovascular related outcomes. That was the goal of the study. And the way that it was designed was such that they had 2 arms, one of which included people who didn't have a uterus and those who did. And so the design of the study was to go for 8.5 years, and they had 4 arms. 4 arms. 2 were separated. They were separated by those with a uterus, those without. Those with a uterus had progestin and conjugated equine estrogen therapy, half of them had placebo. And the other arm, half had placebo and half had estrogen only. Those were the people who didn't have a uterus. It is well known and was established before the study got started that progesterone is essential if you have a uterus to protect from endometrial hyperplasia if you're going to be exposed to estrogen.
What is individual hyperplasia for the audience?
Cancer of the endometrial lining or overgrowth of abnormal cells.
Everybody following so far?
So if you have a uterus, then you need
Progesterone. Or
progesterone.
progestin.
Okay. For
Yes.
cancer prevention.
And
Correct.
that was known as of the 90s.
Okay. So the study arm was designed around with that knowledge at hand. And the results in the first 5 years in the combined arm, those who were on estrogen and progestins, showed an increase in breast cancer. And so the primary investigators decided to stop that arm of the study. And it was a pre-print release before it had even been published. The media got a hold of it and it hit the news. You may remember. Yeah.
Yeah.
And overnight, people quit taking hormone therapy because they heard and read on the news that hormone therapy causes breast cancer. Fast forward 20 some odd years, and there have been post hoc analyses, studies done of those patients with more granular detail and attention to the age at which those patients got them, what they were actually taking, and the short version is that what got presented in the media was a relative risk increase rather than an absolute increase. And I'm going to hand it over to you
Okay.
to talk about that.
The resident nerd?
Yeah.
Okay.
So relative versus absolute risk increase is what I mean.
Okay, we're gonna ninja this thing up a little bit. So the intentions of this study were good. It was a huge study. It's 160,000 women were recruited for this. And as Liz mentioned, there were these 2 populations, those with a uterus and those without. I think the one population without a uterus was only 10,739. And
Very helpful.
but yeah, it's a very big difference. So when you're doing the study, you have to state your hypothesis beforehand. So they're looking at the primary outcomes. And that's like, what are you looking for? So they're looking at breast cancer, they were looking at colorectal cancer, they're looking at heart disease, and they're looking at osteoporosis, in particular hip fractures. These are all things that estrogen was proposed to help with. Notice, I mentioned hot flashes, I mentioned brain fog, I mentioned memory changes. I forgot to mention something before. Estrogen helps the hippocampus with neurogenesis. The hippocampus is involved in making memory. One of the more common things that happens in perimenopause is memory problems. A patient just this past week told me, I'm looking at this mug in my cabinet. I know I bought it. I can't tell you a thing where I got it or where it came from. It's a pretty mug. That's good. Wow. It's profound.
That's the hippocampus.
That's hippocampus,
Oh,
yeah.
that's where you pull us that information from.
Right.
Okay.
And so these primary outcomes aren't looking at the full spectrum of what perimenopause can cause. Looking at very specific questions. And so we have these different study arms, and as Liz said, they plan on doing this thing for a long period of time, and they cut it short because of increased risk of breast cancer, increased risk of heart attacks, increased risk of strokes, and clots. Now, the first out of the gate, the first year, 80% increased risk in heart attacks. Okay. Yeah, went down to 18% in the second year. For clots, they doubled. For strokes, it went up like 42%, equivalent number. And for breast cancer, it went up 24 to 25%. Hit the news, oh my goodness, this is horrible. Everybody off. This is not it. Okay? And people stayed away from this for a while. Until, what did you say, like 4 or 5 years ago?
Yeah.
It's kind of like in the pandemic. People started picking it up, and it became a thing for various influencers to talk about, and it was like there was this revisiting of the data that happened. And thank goodness, because when you really start to take the study apart, you're like, okay, well, let's look at the breast cancer thing. So Liz mentioned a relative risk. So in statistics, there's what's called a relative risk and an absolute risk. So to make it clear, out of 1,000 women, there would be 4 cases of breast cancer. In the study, there were 5. Well, 1 is 25% of 4. So they reported a 25% increase. That's a relative risk increase. Absolute would be the 1 out of 1,000. Okay? So the relative risk sounds big, it sounds impressive. And the same was true for the other statistics I mentioned earlier, the doubling of the rate of clotting, heart disease, and similar. So the relative risk reporting seems very big. That's something that you're really scared of. Let's dig down a little deeper. When we look at the estrogens that were used, they used something called perimenopause, derived from pregnant mare urine, pre-mare urine. And it has various estrogens in it, but it was an oral estrogen. We now know that oral estrogen, the way it's processed in the liver, increases risk of clotting. Okay? So no surprise that oral estrogens increase risk of stroke, clotting, heart disease. No surprise there. Topical applications don't have that, or as much by far. And so an oral Premarin is not estradiol, it's multiple estrogens derived from pregnant mare urine. Increases the liver, which is right here, if I see hold right there, it's where your liver lives, clotting in the body. So kind of no surprise for the increased risk of clotting, stroke, and heart disease. Okay? When we look at the breast cancer arm, it's kind of weird. The estrogen part of that, it's in the post hoc, which means looking back, analysis, the estrogen only part of it, they actually have had less breast cancer. And they were like, what's going on there? And the progestin, you may notice this differentiating between progesterone and progestins. It was a progesterone-like compound called medroxyprogesterone. And an analysis later on showed that medroxyprogesterone can cause increased risk of breast cancer, whereas progesterone, which is what your body actually makes, does not. There's a French study and a study that was published in a wonderfully named journal called Climacteric. That look this up if you want, showing that bioidentical progesterone, which is also available as micronized progesterone in pharmaceutical form, does not increase your risk of breast cancer. So progesterone itself is kind of clear into that. So then we kind of keep cooking along. Everybody following so far? This is kind of interesting. So we keep cooking along. We're like, okay, so they use oral estrogen. We don't want to do that anymore. They use medroxyprogesterone. We don't want to do that anymore. Okay. Well, what can we do? So now people are using topical estrogens, particularly estradiol. And then there's an estriol, remember E3? E3 is its highest when the pregnant, has large effects on the vaginal tissues, helping the vaginal tissues become supple to be able to carry on and deliver a baby. And so people are using estriol on its own to help with the genitourinary symptoms of menopause, or GSM. You can use that on its own. It's quite effective.
So what I hear you saying is that what's changed in the general understanding of the Women's Health Initiative is that the type of hormone replacement is really, really important.
Yeah.
Very small differences in letters make huge differences in outcomes. Like in that context, but progestin versus progesterone, huge difference.
Mm-hmm.
And then how you take that hormone also has a huge difference in outcomes.
And then I'll let Liz speak to this a little bit, but also that when they looked at the study, they were like, there's really not much benefit. There may be some benefit with fracture. There were hints of that. But even that on its own, a hip fracture is a big event. That's a life-changing event for someone later in life that can trigger a downward spiral. But they weren't asking all the other questions about mood challenges, insomnia, and so on, right? So it was a very focused question, worthy question, but it missed the big picture also. And they were starting hormones in women later in life. So these are women who were postmenopausal. And I'll let you talk about this part.
Yeah.
You get that all written down.
So the study participants in the World Health Initiative were somewhere between 50 and 79, which is a pretty broad range. And some people at 50 were barely into the postmenopausal window. So the results that came out in 2002 that ceased use of hormone therapy partly were because the average age of participant was 63. That's quite late to be starting hormone therapy if you haven't been on it already, especially if you went through menopause at 50. So that's 13 years after the fact. So the post hoc, the analyses that have been done, continuing to be done even now, looking at that population, showed that for people between 50 and 59, or who were within 10 years of menopause, who were initiated on hormone therapy, actually had all-cause mortality rate reduction, which is a fancy way of saying any cause of death went down. Later term, during that study window, cardiovascular outcomes improved, meaning the rates of heart attack and cardiovascular related events went down if you started hormone therapy in that first 10-year window.
And hormone therapy being topical with a form of estrogen?
Nope, this was the same group that was on
Same group that
oral
had already been on oral
estrogen
estrogen.
and oral progesterone. Yep.
Okay.
And that the next set of window, which was 60 to 69, had sort of a null effect on cardiovascular outcomes, maybe some increase in general, but then at 70 and up, big time increase in cardiovascular outcomes. So the takeaway at this stage is twofold. We have patients who make up half our population.
Yeah.
All of us will at some point go through menopause or have. If you are able to start
and want to and don't have a contraindication to therapy, if a patient does, the potential long-term benefit much outweighs the risk. And that's this constant
Mhm.
balance that we handle in medicine, is whether it's for hormone therapy or an antibiotic or an antihypertensive or antidepressant or cancer med. It's this balance of risk versus benefit. And I think the thing that I'm excited about now, and that we're going to see as studies continue to come out about more and more about this, is where's the real risk? Because it wasn't really fair the way that it got presented.
Mhm.
So there needs to be more research. But as of right now, if you can start hormone therapy within 10 years of menopause, then that ultimately seems like it helps many different outcomes.
Yeah.
What about managing perimenopause and menopause, not just from a hormone therapy perspective, but looking at nutrition and some of the alternative integrative medicine approaches?
Yeah.
What can people do?
Well,
Good.
it's I feel like a broken record because I say a lot of the same things when I'm talking to patients about how do we want to manage sleep disturbances, or how do we want to manage high cholesterol, or increasing levels of A1C, or 3-month average of blood glucose.
Does everybody know what that means? A1C being your 3-month average of blood sugar and cholesterol. Okay.
So it all, I mean, I was sort of chuckling to myself last night thinking about this and comparing. A lot of the same stuff matters. Getting good sleep has incredible outcomes in all health measures, particularly in this topic we're talking about today. Getting enough fiber, getting enough protein. One of the risks with the menopausal window, postmenopausal window, is sarcopenia, which is loss of muscle mass. And it's not only because we're changing kind of what we do in our lives as a general rule. I mean, getting back to what Brian was saying around our stressful lives and how things are changing in this industrialized life that I think most of us are living in, is a change in our physicalness, and the way that we can combat that potentially with nutrition, getting enough protein.
How much protein generally? And I know it's unique.
It's a lot. It's unique, but a good rule of thumb is if you can get 30 grams of protein 3 times a day, and if you can't do that in a given meal, try to sneak it in with snacks.
30 grams of protein in a given meal, what would that actually look like?
There are a lot of equations for
There
that.
are.
Another
If you
equation
Google
is-
protein calculator, it will help.
but there's a lot of conflicting information.
That's true.
I mean, some people will say you only need 30 grams a day.
Yeah.
Whereas another expert I'm thinking of says 1.2 grams per kilogram of ideal body weight.
I've read that.
Math. And
Yep.
then there's another expert that says 1 gram per pound,
Mm-hmm.
which is a lot of protein.
Mm-hmm.
And so, you got to think about how active you are, what your needs are. So it is very individualized.
Yeah.
But I think that as we move into that age bracket, we need more protein probably than we think we do to prevent muscle loss. Also, resistance training is very important.
And that formula is in perimenopause. We're talking about before we hit menopause is the
In it and up to it, yes.
Yeah, and after?
Yep.
Before, during, and after.
Yeah.
And just because I like to nerd out. So most of your hormones run around your body bound to a protein called sex hormone binding globulin. Various things make that go up and down. The more binding globulin you have, the more your proteins are bound and are free to do so. Having poor nutrition, strangely, makes your sex hormone binding globulin go up, which makes your hormones drop. So something I've seen multiple times is people get into the perimenopausal years, estradiol is dropping, their estrone is going up. They start to get a little more central adipose tissue, and so they go on a diet. And time-restricted fasting, all that stuff is in vogue right now. And unknowingly, they aren't getting adequate nutrition during the feeding window. And they end up sending their sex hormone binding globulin up, which drops their estrogens even more.
Which then does what in terms of symptoms?
Well, it makes them lower estradiol, and in their peripheral tissues, they're making estrone, so they become estrone dominant, which makes this happen more.
So more belly
And
fat,
then
more
together,
adipose tissue.
if you're ready for this, that also poor sleep and low nutrition will tank your thyroid. And so then your metabolism goes down, you start getting thinning hair. That's great.
So this is all interconnected, right? That's what I'm hearing. When I asked
Pull on the threads.
when I asked you, what can people do food wise, you first went to sleep. Right? Sleep was really important. And then it's like, okay, and also food, protein, nutrient dense foods, making fiber, vegetables.
And touching upon fiber, your hormones do so many things, but they circulate through your gut. Okay? You excrete them in your gut and actually get reabsorbed. Usually the ones that are getting excreted are forms that you kind of want to get rid of. And fiber will bind those in your gut and get them out. If you don't have enough fiber in your diet, you're not going to be able to excrete the ones that you don't want. So something.
I was going to say, when people look at their plate, how much fiber is enough fiber?
I like the keep it simple approach.
Mhm.
So you want to have a rainbow of vegetables that are the majority of your plate. Teach your if you're eating meats as a condiment, aim for 30 grams or so. You don't want to power through that. Lots of colors, lots of vegetables. If you like cruciferous vegetables,
Those are amazing.
Steamed cruciferous vegetables have a compound in them called indole-3 carbinol, which becomes dim, which helps with estrogen metabolism.
Okay, back up. Steamed cruciferous vegetables, meaning
Yes.
the vegetables from the brassica family. So
You got it.
cauliflower, cabbage, broccoli, kale, Brussels sprouts, kohlrabi, have a compound called.
You just dropped kohlrabi on us.
I love kohlrabi. I'm a gardener. It's not very often we get to talk about kohlrabi, and really we should. But no, you were saying, what compound do these vegetables have in them that helps with?
It's something called indole-3 carbinol, and it is
Indole-3 carbinol.
metabolism is something called DIM that helps with actually clearance in the liver. So it helps with healthy estrogen metabolism.
Okay.
Get that from your diet.
Okay.
If you really want to pound indole-3 carbinol, broccoli sprouts are the powerhouse of indole-3 carbinol.
Okay. So broccoli sprouts, lots of cruciferous vegetables in the cabbage family, lots of fiber, looking at your plate and seeing mostly a rainbow of vegetables, 30 grams of protein with each meal. What about sleep, though? Let's go back to the sleep part.
Yes.
Because if you're having hot flashes or if you're having insomnia related to lower progesterone, what's within your control to do to optimize your sleep?
Well, it's different for everybody, but the rules of thumb that I try to encourage people to go by are cool rooms, dark rooms. If you have noisy sleepers with you,
Kick them out?
kindly ask them to go someplace else if you can. I mean, that's a very privileged position to be in if you have it. And
You
if
kick the
don't,
dog out of the bed?
yes.
This is a major dog lover.
Yeah, but sleep is,
Sleep is paramount.
your ability to love your dog is inhibited by lack of sleep. Okay. What, earplugs?
Yeah.
Okay.
Mask.
Okay.
Regular bedtime. Regular wake up time. Even if it's the weekend, so it's like, I'm gonna sleep in. Try not to.
That's great.
That's your favorite.
We can all geek out about screens.
Yeah, screens are not great after dark, after the evening has come, and certainly not within 2 or 3 hours before bed, if possible.
Because the blue light that they emit inhibits melatonin, which is our sleepy hormone that helps us fall asleep and stay asleep.
Yeah.
Okay.
Perimenopausal person getting blue light after dark. You're not helping yourself.
Magnesium can be really helpful.
A specific kind?
I like glycinate or citrate.
Okay.
To bowel tolerance. So you kind of take as much as your bowels will tolerate. If you're super sensitive to it, sometimes the combinations that have citrate and glycinate and
3-in-8?
and malate are a little kinder on the gut.
Mm-hmm.
They're also helpful for headache sufferers. So if any of you have headaches, they can be helpful for that. If you're tight in your muscles, it's also good for that. If you tend toward constipation, it's actually pretty lovely for that.
Can I chime in on that one?
Please.
There's lots of kinds of magnesium. There's aspartate, glycinate, oxide, 3-in-8, and others.
And more.
And more. The glycinate form is usually the best tolerated for those that have bowel problems with it. magnesium citrate is actually a pretty potent laxative. Most people can handle 400 milligrams up to twice a day of glycinate. The 3-in-8 form dose is very different. It's 2 to 3 grams.
Wow.
The 3-in-8 form can be helpful for those who have more anxious symptoms. It has an extra effect there.
So magnesium 3-in-8 is helpful with anxiety in
A little
addition.
more, yeah.
The dosing is very
And,
specific.
The taurate form is often favored for people who have cardiovascular concerns.
Magnesium taurate for cardiovascular. Magnesium 3-in-8 is helpful with anxiety. All of it's helpful with sleep, muscle tension. Malate is really good for muscles. Citrate, magnesium citrate tends to relax the bowels more.
Magnesium is the great relaxer.
Uh-huh.
Choose what you want to relax.
Yes. Okay, so for sleep, what's within folks' control? Minimize screens or cut them out at night. Have cool place to sleep. Have it be dark, comfortable, quiet. Magnesium is helpful.
There's a laundry list. There's a great people have different opinions about Huber these days, but he has a great sleep summary that's available online. I mean, there's all sorts of nervine teas. She's an excellent herbalist. She did not say that about herself earlier.
No, I guess I need to work on my introduction. Thank you.
All sorts of nervine teas that can help. Theanine, which is derived from green tea, which is very calming. There's so many things in the realm of sleep that I think everybody in primary care became sleep specialists during the pandemic because everybody had insomnia. We could do a whole, maybe we should.
Yeah,
sleep.
we should. Anybody interested in that? Yeah, me too.
And I think eventually we're going to start talking about prescriptions and medications.
Yep, we're going to segue towards that right now.
One quick thing though I want to say.
Please.
I, particularly for my patients in this arena, in the menopause and perimenopause window, if you're struggling with sleep, one of my favorite things is to remember to treat yourself like you would an infant at bedtime. Quiet, cool, calm, and repetitive, day after day after day.
That's good.
Babies sleep better when there's consistency, when there's like, oh, this is signaling to me when I smell this thing, when I put this set of clothing on, when I go in this particular part of the room, when I sit down, I do this thing. Your body starts to be like, oh, this is the time. Got it.
So creating a sleep ritual or sequence, much as you would for an infant, but adapted for your adult self, that really lulls you into relaxation. Maybe not. Yeah. What about with exercise? Are there specific forms of exercise that are indicated for this time? What? What you said? Just do it. Just do it. Okay, just move.
Move in whatever way you like.
How much? For how long? For how intense?
That's probably a whole conversation into itself.
Yeah.
I would say that the predominant sort of obsession with cardiovascular exercise and doing cardio is kind of maybe on the way out, and really focusing on muscle building is where I would recommend. So one of these menopause specialists that I have learned a lot from is obsessed with saying strong, not skinny. And I echo that. So whatever you can do to get strong is cool. It's good for muscle building. Stronger muscles keep your bones healthy. More muscle uses more energy, so there's better
Metabolism.
Exactly. So
And muscle helps with insulin sensitivity, and,
Which is good.
Blood sugar regulation. And one of the things that can happen with the dipping estradiol is your insulin sensitivity can be affected. Insulin is a hormone that gets the sugar out of the blood into its cells. So if you don't have good insulin sensitivity, you can get elevated blood sugars. So.
Which tends then towards prediabetes and diabetes and metabolic syndrome and all of that. So we've talked about food, protein, fiber, exercise, sleep.
Yeah.
We spoke on some of the supplements in terms of magnesium, in terms of L-theanine. Is there anything else in that realm? Vitamin D.
Yeah. I did want to touch a little more on exercise.
Okay.
There's some sayings I repeat multiple times a day with patients, and I have to take this lesson myself. You ever heard the phrase "exercise is an optional at 40"? Daily exercise is an optional at 50. Strength training is an optional at 60. Balance training is an optional at 70. Better to start all at 40. It's kind of like the best time to plant a tree was 10 years ago. And so when we think about how we're going to be strong, independent, and mobile in various decades of our life, knowing that starting around 50 or so, if we aren't trying to keep muscle, we're actively losing muscle. If we aren't trying to keep our balance, we are actively starting to lose our balance. Now, we aren't fated to lose these things. If we stay active, engaged, and curious in using these things, you can actually grow them back. Like we've seen people who've had strokes, they lose their balance. They miraculously, through a lot of consistent. And so when you ask like what exercise is the best, first of all, it's the one you do.
Yeah.
And the one you'll do on a regular basis. And whatever motivates you, whether your exercise is your quiet time, whether it's your social time, whether, I don't know, that's something for you to figure out.
But finding ways to move and move consistently that hit the different zones of just moving and building strength and balance, so that you're hitting all those categories.
Yeah.
Okay. And then going back around to supplements and pharmaceutical interventions, what is within people's control to do?
Can I tee this up and you pick it up? We'll chat about
Got a few more minutes.
Sure.
Yeah, let's go.
Hopefully he won't mind if we go a little over.
We might need to.
Nothing as a medical provider, well, almost nothing will make you more humble than trying to treat perimenopause. I've been to a few hormone training conferences. They all pitch it. It's so easy. You do this, you follow this recipe, and you go out in the wild and try to practice it, and it kind of works. Then you find these situations where it definitely didn't work well. And so part of our goal tonight was to destigmatize it, talk about what's going on, and to help people understand what the symptoms are, where they may be coming from. Because when you're going through perimenopause, if you can be aware of, wow, I'm not remembering things as well, or I'm at work and I'm having trouble focusing, I'm feeling overwhelmed, or I look in the mirror and I don't recognize myself, or I can't sleep, or I just bit my kid's head off. Ooh, where did that come from? It takes a lot of self-awareness to be able to work with yourself and with your medical provider to know what's best. Because if you're trying to treat with medication too strong, it's going to be dosed appropriately sometimes and not at others. And so often in perimenopause, when you start to bring medications on board, so estrogen or progesterone, or maybe estriol or DHEA, a typical approach is to come in kind of low and then treat the symptoms that break through with herbs and supplements that are needed. So you want to help people understand, like, okay, for hot flashes, you can actually use black cohosh, which acts centrally and not hormonally, and it can work pretty darn well.
At what dosage?
That's individual too. Yeah.
Talk to your provider.
Yeah, but their perimenopause is individualized thing as you move through this transition, and to become familiar with what your symptoms are, how you respond in your body. Lifestyle is the foundation of it.
Yeah. So one thing about talking about hormone therapy specifically in prescriptions is that we've taken on learning this because we didn't learn it in school. We have patients have them, want them to help.
Yeah.
And so we learn because we need to. We learn because we want to. There was a study done last year. It was like a survey of 700 and some recent graduates from medical school, asking how confident are you in treating perimenopause? And like 6% of them said I could treat it, menopause and perimenopause. That's like 20 people. It's not a huge study. It's like not big. But the point is,
it was 6, not 66.
6%. That's recent.
Something that's going to affect over 50%.
So my point is, if you aren't a patient at our clinic and you're wanting to find someone who's good, ask around, talk to people. The Menopause Society website is good. I'm sitting for that exam later this year. Just because it's on the website doesn't mean they're good. You got to keep sleuthing and find who's good.
True.
Also, recognize that if you can't find somebody locally, there are online platforms, but the numbers are growing. There are people out here who want to treat, who want to help, but it's woefully slow. And they're out there. And it may require looking, and the other participation on this is on you to talk to your friends, talk to your family, talk to the people in your life, and
Yes.
educate and read. And there's so much available online. You just have to be a little bit discriminating about who you're listening to.
Are there specific names or websites that you feel are good sources for people to go to?
I think mentioning names of people would be appropriate, but I mean, names is
Yeah, Menopause Society is a great place to start. The International Menopause Society is another one that's very good.
Okay.
Yeah.
Yeah, I think that discernment with a capital D is definitely warranted. In the world of influencers and social media, everybody's kind of looking for their angle to make a statement, contrast against other people. So some people are going to be like, oh, you must do pellets, or oh, you must do creams, or oh, they didn't get pregnenolone, they're stupid. It's like everybody's trying to differentiate and like they're the master of hormones or whatever, but it's, use your discernment. What we're trying to present tonight is, these are the array of symptoms that can arise. Perimenopause is unique to every woman, and it can change based on what you have going on in your life. If you have a big stressor happen, your symptoms are going to change. Big change in your diet, your symptoms are going to change. And so being able to work with someone who is able to have a dialogue with you and tune things as you go, and you become really confident and the expert of your own body and your own symptoms, that's really what we'll encourage.
I have a question for women in their 40s that come in and there's no contraindications and they're like, I've noticed all these symptoms, I think it might be perimenopause. Is there any resistance you would have to allowing them to try that tool? Because I personally have run against that. I'm a therapist, I work with clients, and I'm like, you should ask about this. They're like, well, I asked and I said no. And from what I'm reading, it seems like a great tool to try to see, does this help the symptoms?
Absolutely.
But
Yeah, I think it depends on the relationship that the patient has
So,
with their provider.
Let me pause for just a second and
Yeah.
repeat the question
Oh,
so anybody
yeah,
joining
yeah,
online
yeah.
can hear it. As I understood, when you're a therapist and you're working with clients who have symptoms where you feel like some form of therapy or interventions would be really helpful during perimenopause, menopause, but these clients say they talk to their doctors and the doctors don't help them or say they can't do anything, then what? What can you do?
Or, I mean, is there a reason you wouldn't want to afford them that tool?
Or is-
And I'm just not understanding because I'm not a medical doctor.
Sure, yeah. We can both pitch in on this.
Just repeat the question as you answer.
Sure. So the question was, is there any reason why we wouldn't want to do it?
In a perimenopause.
In a paragraph, yeah. So it's all going to be very individualized to the person. And you have to take their full history, risk history, where their symptoms are coming from, and try to discern whether their symptoms really are from perimenopause or from other things. And that takes a little work. As I mentioned earlier, progesterone tends to trend down early, not always. And so it's not uncommon to use a little progesterone first to see if that's going to help with some of the anxiety or the insomnia, if those might be the symptoms. But you have to be careful with that, because if you do too much of that, you're going to affect the lining of the uterus, endometrium, and you can get breakthrough bleeding and symptoms like that. Right? And then one of the curious things about progesterone, I love that hormone, that it likes to taunt me like nothing else. For some reason, and people have such a varied response to progesterone. Some people are exquisitely progesterone sensitive, and they'll have dramatic effects. Someone who can't tolerate 25 milligrams, someone at 300. So the dose range is very. And when you're in the perimenopause years, if you're still cycling in a cycle, sometimes progesterone can be pulsed, so it's not to drive your cycle, or use a very low dose of progesterone So if you're actually not dropping the cycle, progesterone is largely what's timing the cycle.
Brian, what are some of the risk factors that would predispose somebody to having their doctor say, we are not going to recommend hormone therapy?
History of breast cancer.
Okay.
That's going to give most people the willies.
Yeah. So if somebody is presenting with a history of breast cancer, that would be a compelling reason for a doctor to say, this is not something I can do.
Does that also include family history?
No.
That's
surprising.
Why?
Family history is not a contraindication for hormone therapy for the patient in front of you.
Is that true with regards to blood clots, heart disease, etc.? Like it's all of these potential.
Patient in front of you. You want to take into consideration family history, of course, but it is not a contraindication if a family member has had breast cancer to consider giving the patient in front of you hormone therapy.
So if that individual themselves has had breast cancer or another form of cancer?
So yeah, it's probably worth going through. The current contraindications to hormone therapy include active breast, endometrial, ovarian cancer, or any estrogen or progesterone sensitive cancers, a recent cardiovascular event like a heart attack or stroke, a recent PE or DVT, deep vein thrombosis.
Embolism.
Yes,
PE.
PE. Not the class we took in.
Blood clots and pulmonary embolism. Submittance. Yeah.
Yep. Significant liver disease.
Covered.
Oh, being pregnant.
Right. It's a good one to mention. Yeah,
Sorry.
it was important to mention it.
We actually give progesterone sometimes to women who are
Right.
pregnant over 35.
But not
to share your babies.
yeah.
But not, yeah. Does that answer your question? Okay, it's 7:06. Do we want to take a few more minutes for questions or have people submit questions after the fact?
Was there anything else you wanted to say?
No, I'm just hopeful that conversations like this can continue to happen, to proliferate, to go back to your communities and share this because it's changing and it's coming and we need more voices. One thing I did want to say,
Please.
there is some funding being set aside in Congress. Joe Biden led the charge on this, but there's some money coming for studies. And there's work at that level that's going to be required in order to get robust, more robust data about what we're actually looking at. Because where we are now is it's clear what we can't use it for. It's clear where the no-nos are. And I think that the yes is much broader, but in order to really sit safely in that, we need more data.
Especially considering how different each woman, each female-bodied person is with regards to 25 milligrams of progesterone versus 300 milligrams of, and that too, like if a provider hasn't been able to or hasn't known to do additional studying like these two have, then they just might not know what to do or have had a bad experience potentially.
For you specifically with your patients, I would say keep asking, find another provider who can help with that specifically.
International Menopause Society
And the Menopause.
and the Menopause Society may be resources. Anybody else have any questions? Yeah.
So let's say there are no contraindications. The patient is in perimenopause or within the first 10 years of postmenopause. Post. But they have tested, and we know for a fact they have low progesterone or estrogen, blah, blah, blah.
Mm-hmm.
Is there a reason? And there are no symptoms. This person has no symptoms, crazily enough. Are there any reasons why this person should supplement their low hormone levels with hormone replacement?
So if somebody is in perimenopause or within the first 10 years after menopause, and they are not having symptoms of hot
And I made
flashes,
this person up.
Obviously.
They exist,
Yeah.
But you get my ass.
right.
I have a family of them. I'm not kidding.
If you
are you people?
So if you've got somebody who's not having symptoms, but their tests are showing lower hormone levels for progesterone, estrogen, are there compelling reasons to treat?
Benefit to the body, to the physical body to replace that.
Right. So I think Liz and I both can speak to it. So not everybody who goes through perimenopause is going to be symptomatic. There's this anonymous family. I love them. They're great. They know what I'm talking about. And in menopause, on the other side of this, in a period for 12 months, your hormone levels have mostly stabilized. Your receptors have been able to upregulate to meet that level. And so it's not just your hormone levels, it's also what's happening at the level of the cells. So the cells have become more sensitized. It's not going to be what it was pre-menopause, but it's also maybe not as bad as it was sometimes during perimenopause when there's such a mismatch. Okay. And so that's what Liz was saying. It looks like being on, they've changed it from HRT to NH2, menopausal
It
hormone
depends on
therapy.
who you're talking
Yeah.
to.
So being on hormone therapy, it looks like it may help with osteoporosis and hip fractures. It looks like there may be cardiovascular benefit. It looks like there may be benefit with dementia prevention and other things. And so I wish the studies were done, but now there's funding to do it. So we're in this window where people have a choice. Do we want to do this looking at the risks and the benefit and their family history and say, well, to me, this seems to be worth it. So it's going to be a personal choice, really, to have a lot better data.
So short to just summarize, we need more data to emphatically say, but also it depends, and it's a unique situation. Each individual would be unique.
And I think family history can inform that discussion and decision-making process also.
For the sake of our time,
Can
I'm
I
going
say
to
one more thing?
yes.
This is very
Last
important.
thing.
This is very important to me because I unexpectedly take care of a lot of perimenopausal patients. I take care of a lot of thyroid patients. It just turns out that a lot of autoimmune thyroid happens at this time period. Didn't see that one coming. And a lot of them suffer silently. And they suffer silently. And it's something that they don't want to talk to their friends about. They don't want to talk to their partners about it. They are in the bathrooms crying. Sometimes struggling to get through the day to take care of their families and their kids. And this isn't what happens for everybody, but there's enough of these people out there, just like it used to be said, that if there's more awareness of what these symptoms are and the stigma is taken away, so that people can talk about it and they know that there are great options that work, that's really our purpose for doing this talk.
Thank you for showing up and being here, whether you're online or in person, to be a part of this. Thank you both for sharing what you know and for prioritizing this.
Thank you for your
It's an honor. Thank you.
excellence and facilitating.
Thank you. Appreciate it.